Welcome in Pediatric Lecture Series. Myself, Dr. Sunil Natha Maske, Professor in Pediatrics, also working as a Dean in Dr. Vithalrao Vikhe Patil Foundations Medical College, Ahmednagar. In today's lecture, we are going to see a new topic, that is the neonatal jaundice, which is very common in neonatology as well as in the pediatrics. The term jaundice is from the French word that is jaune, Jaune. Neonatal jaundice may have first been described in Chinese textbook 1000 years ago. The earliest work on jaundice is from the Booms in 1785, also by Herwig 1847. Also in 18th and 19th century references in the medical thesis, essay and textbook, we can see the discussion about the causes and treatment of the neonatal jaundice. Later on, we are going to see new terminology, that is the kernicterus, which was first described by Jones Orff in 1875. He postulated that jaundice might have hematological origin, and in adults, jaundice brain is not affected. Whereas in 1904, Christian Skurmer, he has coined the terminology kernicterus, that is the jaundice of the kern, Kern, that is the nuclear region of the brain. Neonatal jaundice or neonatal hyperbilirubinemia is the yellowish discoloration of the white part of eyes and skin of a newborn baby due to high bilirubin level. In 60% of the full-term newborn and 80% of premature newborn have neonatal jaundice. 3% of normal term infants show bilirubin level more than 15 mg per deciliter. Neonatal jaundice is a common condition that requires medical attention and hospital readmission in neonatal age group. This is the bilirubin molecule, which is non-polar water-insoluble compound requiring conjugation with glucuronic acid to form water-soluble product that can be excreted. And this bilirubin circulates to the liver, reversibly bound to the albumin. This is the molecular structure of the bilirubin. Now, pathophysiology. Bilirubin comes from the breakdown of the heme, which is produced from the breakdown of the hemoglobin, which is a part of RBC. This heme is converted to biliverdin, iron, and carbon monoxide by the enzyme heme oxygenase. Biliverdin is then converted to bilirubin by biliverdin reductase. The conversion of heme to bilirubin takes place in the reticuloendothelial system. The conjugated bilirubin is hydrophobic and is transported to the liver bound to albumin, where it is conjugated by the urine diphosphoglucuronic transferase UGT. Conjugated bilirubin, which is water soluble, is excreted in the bile into the gastrointestinal tract and mostly excreted in feces after being metabolized by the bacterial flora. Some conjugated bilirubin is deconjugated to unconjugated bilirubin and is reabsorbed through the enterohepatic circulation. This is in short about the heme molecule to conjugated and unconjugated bilirubin. One terminology in neonatal jaundice is liganding. It is responsible for transport of plasma membrane to endothelium. Bilirubin conjugated in presence of urine diphosphate glucuronidase, that is UDPGT, to mono and diglucuronide, which are then excreted into bile canaliculi. Phenobarbital increases the concentration of ligandin and also induces the UDPGT. Conjugated bilirubin is water soluble and is secreted by the hepatocyte into the biliary canaliculi. It is converted to stercobilinogen, urobilinogen, colorless by bacteria in the gut. And some stercobilinogen may be reabsorbed by the gut and re-excreted by either the liver or kidney. Meconium contains near about 100 to 200 mg of conjugated bilirubin at birth, and this conjugated bilirubin is unstable and easily hydrolyzed to unconjugated form. This occurs non-enzymatically in duodenum and jejunum in presence of beta-glucuronide, which is the enteric mucosal enzyme found in high concentration in breast milk and newborn infant. Clinically, Jaundice in adult is visible when the serum total bilirubin is more than 2 mg per deciliter, and in neonate if it is more than 5 mg per deciliter. There are certain risk factors for neonatal jaundice. Like first one is the premature baby. Those who are born before 38 weeks of gestation are very prone for neonatal jaundice because of the less feed intake, low bowel movement, which leads to the less bilirubin elimination from the gut. Second, significant bruising during the birth, like birth trauma, birth delivery process injury, which causes higher level of bilirubin from the breakdown of more RBC. Third is the blood type. If the mother's blood type is different from her baby's blood group, the placental antibodies crossing, which causes rapid breakdown of the red blood cells. Also, breastfeed babies. If there's the less breastfeeding, which causes dehydration and low caloric intake, ultimately leading to the RBC destruction and risk of the jaundice. And studies have shown that East Asian ancestry have increased risk of the developing neonatal jaundice. Now, classification. There are various types of classifications are there. Some are depending on the onset, some are depending on the location of the cause. Now, first one is depending on the cause is the distributed into three types: pre-hepatic, hepatic, and post-hepatic. In pre-hepatic, it leads to the increased bilirubin load are distributed into two groups: hemolytic and non-hemolytic. Hemolytic cause may be Coombs positive or Coombs negative. In non-hemolytic, extravascular source may be there like polycythemia, exaggerated intrahepatic circulation. Second is hepatic, where there is a decreased bilirubin conjugation. It may be physiological jaundice, Klinger-Nazar syndrome 1 and 2, Gilbert syndrome, hypothyroidism, breast milk jaundice. Third cause, third group is the post-hepatic, where there is impaired bilirubin excretion, may be due to biliary obstruction, metabolic disorders, chromosomal abnormality, infection, and drugs. A very important classification which commonly used where the neonatal jaundice is distributed into two broad groups is the conjugated bilirubin and unconjugated bilirubin. Conjugated may be hepatic and post-hepatic cause, just we have seen. Unconjugated bilirubin may be physiological jaundice of the newborn or it may be pathological jaundice. Pathological jaundice is distributed into two groups, may be hemolytic, non-hemolytic. And in hemolytic, cause may be intrinsic or extrinsic. In short, this is the unconjugated and conjugated type of neonatal jaundice. Unconjugated may be due to increased production, may be due to ABO incompatibility, G6PD deficiency, cephalhematoma, significant bruising at birth, other immunoglobulopathies, or RBC membrane defects. Also due to reduced clearance, may be due to Gilbert syndrome, Crigler-Nazar type 1 and 2, hypothyroidism. Third one is the increased enterohepatic circulation like breastfeeding jaundice, breast milk jaundice, ileus or intestinal obstruction. Conjugated type we have seen just now may be anatomic due to biliary atresia, choledochal cyst or Alagille syndrome. May be due to metabolic, tyrosinemia, galactosemia, hypothyroidism. Conjugated type may be due to infections like UTI, sepsis or torch infection, or in others group, idiopathic neonatal hepatitis or due to parental nutrition related cholestasis. Third classification depending on the time of onset of jaundice. It may be early jaundice due to hematoma, infection, maternal hemolytic anemia, hemolytic disease, Gilbert syndrome, Dubin-Johnson syndrome, Rotar syndrome, Crigler-Najjar syndrome. In following conditions, jaundice is prolonged due to breast milk jaundice, infection, hypothyroidism, hepatitis, biliary atresia, duodenal atresia, galactosemia, choledochal cyst. Third is the conjugated bilirubin. We have just seen due to parental nutrition, infection, cystic fibrosis, hypothyroidism, hepatitis, biliary atresia, duodenal atresia, and choledochal cyst. Now we are going to see one by one. Pathological jaundice, we have seen it is under the subgroup of the unconjugated hyperbilirubinemia. It occurs within first 24 hours of the life within birth. It is characterized by rapid rate of rising in the bilirubin level more than 0.2 mg per deciliter per hour or 5 mg per deciliter per day. It may be due to increased bilirubin production, decreased bilirubin clearance, or increased enterohepatic circulation. The causes may be immune, ABO-RH incompatibility, or non-immune due to cephalhematoma, RBC membrane defect like hereditary spherocytosis, elliptocytosis, enzyme defects like glucose 6-phosphate dehydrogenase deficiency or pyruvate kinase deficiency. There are certain signs of pathological jaundice. Intrauterine growth retardation, stigma of intrauterine infection like cataract, small head, enlarged liver and spleen, cephalometoma, bruising, bleeding into the brain, family history of jaundice or anemia, family history of neonatal or early infant death or maternal illness suggestive of viral infection, anti-malarial drugs if mother has taken leading to G6PD deficiency or sulfonamide intake by the mother. There are certain red flag signs for pathological jaundice. Jaundice occurring within first 24 hours of life, rapidly rising total serum bilirubin concentration, early gestational age, previous siblings with jaundice, significant bruising, jaundice persisting for more than 2 to 3 weeks, East Asian ethnicity. Physiological jaundice. It is very common, also known as non-pathological jaundice. It is mild and transient, does not require any treatment. It occurs because of difference in the metabolism of bilirubin in the neonatal period, leading to increased bilirubin load. And this increased bilirubin load it is due to the increased production of bilirubin due to higher mass of red blood cells with decreased lifespan in neonates. In adult it is 120 days, in neonates it is 840 to 80 days. Also due to decreased bilirubin clearance from the deficiency of uridine diphosphate glucuronide transferase UGT enzyme, which in newborn its percentage is less. And also very important is increased enterohepatic circulation. Physiological jaundice usually occurs on 2nd to 4th day. It peaks between 4 to 5 days and disappears by 2 weeks. Remember that physiological jaundice never occurs within first 24 hours of birth. And this elevation is due to elevation of the unconjugated bilirubin. There are two phases in the physiological jaundice. Phase 1 occurs in term infants, which lasts for 10 days with rapid rise of serum bilirubin up to 12 mg per deciliter, whereas in preterm, it persists for 2 weeks and with rapid rise of serum bilirubin up to 15 mg per deciliter. In phase 2, bilirubin level declines to 2 mg per deciliter for 2 weeks, which mimics to adult value. In preterm, phase 2 can last more than 1 month. Also in exclusively breastfed infant, phase 2 can last for more than 1 month. This physiological jaundice, the causes we have just seen, in short, increased bilirubin load over liver cells. It may be due to increased RBC volume per kg as compared to adult, decreased RBC survival with 90 days, increased early level bilirubin from heme proteins, myoglobin, heme converting liver enzyme, and ineffective erythropoiesis, or increased enterohepatic circulation of bilirubin due to no bacterial activity in the gut, beta-glucuronide, which is unconjugated bilirubin, diglucuronide present in the intestine, which helps in the reabsorption of bilirubin in the portal circulation. Also due to the decrease in ligandin and binding of ligandin and hidden protein by other anions, or maybe due to defective bilirubin conjugation. In short, we are going to see the difference between physiological and pathological jaundice. Clinically, physiological jaundice is visible after 2 to 3 days. Pathological jaundice is visible within 24 hours of birth. Serum bilirubin rise is less than 5 mg per deciliter per day in physiological. In pathological, it is more than 5 mg per deciliter per day. Total serum bilirubin in term is less than 12 mg per deciliter, and preterm it is less than 15 mg per deciliter in physiological jaundice. Whereas in pathological jaundice, in term it is more than 12 gram per deciliter, and in preterm it is more than 15 mg per deciliter. Whereas jaundice persists in physiologically is less than 1 week in term and less than 2 weeks in preterm. Whereas in pathological jaundice, it persists more than 1 week in term and more than 2 weeks in preterm. Now, ABO incompatibility. After physiological jaundice, ABO incompatibility is major cause of pathological jaundice in newborn. This occurs in mothers with blood group O who have anti-A and anti-B immunoglobulin G antibodies, which crosses the placenta and causes the hemolysis in the newborn with blood group of A or B. That means here the mother's group is O and baby's blood group is A or B. And where the IgG antibodies which crosses the placenta and which causes hemolysis. This frequently occurs during the first pregnancy without prior sensitization. Now Rh incompatibility. Here the mother is Rh negative, baby is Rh positive. There is a leakage of fetal RBC into maternal circulation. This maternal sensitization to D antigen on fetal RBC occurs. Production and transplacental passage of maternal anti-D antibodies into fetal circulation, which causes hemolysis and destruction of antibody-coated fetal RBC. RBC hemolytic disease was rare during the first pregnancy with Rh positive features, but subsequently it occurs, whereas ABO occurs in first and Rh occurs later on because sensitization occurs on re-exposure. And anti-D immunoglobulin, anti-D gamma globulin is given as a prophylaxis to mother on exposure to baby also. In short, Rh and ABO incompatibility frequency. Rh incompatibility is rare compared to ABO. ABO is common. Anemia is marked in Rh, whereas in ABO it is minimal. Jaundice in Rh incompatibility is more compared to ABO. Fetus hydrops occurs commonly with Rh incompatibility. ABO is rare. Hepatosplenomegaly and Kernicterus chances are more in Rh incompatibility compared to ABO. That means Rh is more dangerous. Blood findings are also there. Anemia is marked in Rh. In ABO, it is less. DCT is positive in Rh. In ABO, it is negative. ICT, indirect home test, is positive in Rh and usually positive in ABO. Hyperbilirubinemia is more in Rh than compared to ABO. And you see nucleated RBC in Rh and spherocytes in ABO. Now, next cause is G6PD enzyme deficiency, glucose 6-phosphatidehydrogenase deficiency. This enzyme found in the red blood cells, which protects against the oxidative injury by the production of NADPH, nicotinamide adenine dinucleotide phosphate hydrogenase from nicotinamide adenine dinucleotide phosphate NADP. With its deficiency and presence of oxygen stressors like illness, certain drugs, dyes, foods like thiophins, there is hemolysis of RBC. And clinical presentation is the pathological jaundice, which is severe may lead to kernicterus. This G6PD deficiency is X-linked disorders. Mostly males are affected and females are asymptomatic carriers. Next cause under pathological is the Crigler-Najjar syndrome. There is either absence of UGT activity type 1 or low UGT activity type 2, which lead to severe neonatal jaundice in first day of life and less severe disease respectively in first and second two types. Neonates with type 1 needs liver transplant or long-term use of phototherapy, and phenobarbital is required in type 2 Crigler-Najjar syndrome. Now, Gilbert syndrome. There is a mutation in the UGT1 and A1 gene which causes decreased UGT production and unconjugated hyperbilirubinemia. It is also diagnosed in adolescent period, although its presentation may start in neonatal period. And it is autosomal dominant disorder. It is diagnosed with the help of genetic testing. Now, very, very important two terminologies. That is the breastfeeding jaundice and breast milk jaundice. There are differences in both these two. Breastfeeding jaundice is also known as breast failure jaundice. It occurs in the first week of life. It is due to failure of adequate intake of breast milk leading to dehydration and hypernatremia. Breastfeeding failure leads to decreased intestinal motility and decreases the elimination of bilirubin through the stool or meconium. This also leads to increased enterohepatic circulation, resulting in increased reabsorption of bilirubin from the intestine. In most cases can be ameliorated by frequent breastfeeding sessions with sufficient duration and to stimulate the milk production. So breastfeeding jaundice is due to the inadequate breast milk. Whereas breast milk jaundice occurs in late first week, it peaks in second week and usually resolves by 12 weeks of age, that is 2 months. It is due to inhibition of UGT activity and a factor in breast milk with beta-glucuronidase-like activity that deconjugates the conjugated bilirubin in the intestine, leading to increased enterohepatic circulation. It is a biochemical occurrence, whereas breastfeeding jaundice is a mechanical process. Here in breast milk jaundice, bilirubin uptake in the gut, that is enterohepatic circulation, is increased in breastfed babies due to increased level of epidermal growth factors (EGF) in breast milk. Breast milk also contains glucuronidase, which increases the deconjugation and enterohepatic recirculation of the bilirubin. And the enzyme in the breast milk, that is lipoprotein lipase, produces increased concentration of non-esterified free fatty acid, which inhibits the hepatic glucuronidase transferase, which again leads to decreased conjugation and subsequent excretion of the bilirubin. So these are the two things: breastfeeding jaundice and breast milk jaundice. Now we are going to see the conjugated hyperbilirubinemia. Till now we have seen the unconjugated hyperbilirubinemia, that may be physiological jaundice, that may be pathological jaundice, that may be hemolytic, non-hemolytic. Now conjugated type always pathological, and is due to the defect in bile formation, transport, obstruction to its flow, or due to the systemic conditions which affect the liver. Conditions which causes conjugated hyperbilirubinemia due to hepatobiliary diseases like biliary atresia, choledochal cyst, idiopathic neonatal hepatitis, Alagilla syndrome, TORCH group of infection, that is toxoplasmosis, syphilis, varicella zoster, rubella, CMV, and herpes simplex infection, may be due to inborn error of metabolism like galactosemia, genetic disorders like antitrypsin 1 deficiency, metabolic disorders like tyrosinemia, UTI, systemic infections like sepsis, shock, and birth asphyxia. Now we see the one by one of the conjugated jaundice. Biliary atresia is most common cause of conjugated neonatal jaundice. It involves both intrahepatic and extrahepatic bile ducts, usually present 2 to 4 weeks of life with very typical pale stool. Initial evaluation is done by USG, which shows triangular cord sign. You have to do the percutaneous liver biopsy and open cholangiogram, and treatment procedure is a Kasai operation, which is called as hepatoportoenterostomy, which should be performed before 8 weeks of life. Now, choledochal cyst is also cause of conjugated type of neonatal jaundice, which involve dilatation of intrahepatic and extrahepatic bile duct, which is diagnosed by the ultrasonographically. Now, Alagilla syndrome. It is caused by genetic mutation leading to a paucity of interlobular bile ducts and hepatic manifestation including jaundice and cirrhosis. In this syndrome, other findings will be butterfly vertebrae, peripheral pulmonary stenosis, renal involvement, dysmorphic features, and posterior embryotoxin of the eye. This syndrome is inherited as the autosomal dominant pattern. Now, alpha-1 antitrypsin deficiency. It is very common genetic disorder which presents with cholestatic jaundice in infants, and it is homozygous with PiZZ genotype. There is accumulation of antitrypsin polymer in the endoplasmic reticulum of the hepatocytes, and which leads to apoptosis, neonatal cholestasis, and cirrhosis in later childhood life. Galactosemia is inborn error of metabolism. Here the baby presents with jaundice, cataract, hepatomegaly, failure to thrive, renal tubular acidosis, E. coli sepsis after the ingestion of milk. It is due to glucose 1-phosphate uridyl transferase deficiency, which leads to the accumulation of toxic metabolites in the multiple organs, and presence of reducing substance in the urine suggests galactosemia. In short, general symptoms of neonatal jaundice are yellow skin, yellow eyes, that is the sclera, sleepiness, overfeeding, brown urine, fever, high pitch irritable cry, and vomiting. Now we have to do the clinical examination of the neonatal jaundice baby. The one score which is commonly used by the uripediatrician or neonatologist in the clinical assessment of the neonatal jaundice is described by Kramer. It is the dermal staining of the bilirubin which may be used as the clinical guide to the level of jaundice. Dermal staining in the newborn progresses in the cephalocaudal progression, which is in the figure. Newborns should be examined in good daylight. Physician should pale the skin by digital pressure, and underlying color of the skin and subcutaneous tissue should be noted. Ideally, we should do the pressure on the tip of the nose or the hard bony points. Newborn who are detected the yellow skin beyond the thighs should have urgent laboratory confirmation of bilirubin. Clinical assessment is unreliable if newborn has been receiving the phototherapy or has a dark skin. This is the Kramer staging. Also, it is modified Kramer staging. According to dermal zone, it is divided into 5 groups. If the jaundice is clinically limited up to phase, approach bilirubin level is 4 to 6 mg per deciliter. If it is chest and upper abdomen, level is 8 to 10 mg per deciliter. In third dermal zone, it may be lower abdomen or thighs. Appropriate level of the bilirubin is 12 to 40 mg per deciliter. In the fourth dermal zone, it may be arms or lower legs, it is up to 15 to 18 mg per deciliter. And fifth dermal zone, it is up to the palms and soles. That means it is 15 to 20 mg per deciliter. This is about the modified and regular Kramer staging. In short, if the jaundice occurs within first 24 hours of life, it is mostly pathological, just we have discussed. It may be torch or hemolytic disorder. If it is on the second day to third week, it is physiological, which this happens by first week, breast milk, sepsis, polycythemia, cephalomegalemia, Criglan, Nazar syndrome, and hemolytic disorder. And appearance or persistence of neonatal jaundice after 3 weeks, mostly it is due to breast milk, hypothyroidism, pyloric stenosis, and cholestasis. Now, diagnosis of neonatal jaundice. One, we have seen the clinical assessment or its appearance. Roughly, we can distinguish the causes. Gold standard method for bilirubin estimation is total amount of conjugated bilirubin, total and direct, based on the Vandenberg test reaction. You can do with the help of spectrophotometry, which is based on bilimeter, which assesses the total bilirubin in the serum, which is the non-invasive method. Then is the transcutaneous bilirubinometer. It is also non-invasive method, but accuracy you have to check. Along with this serum and total bilirubin, we have to do the blood group and RS typing, hematocrit, reticulocyte, and peripheral blood smear, direct Coombs test and indirect Coombs test, depending on the ABO and RH incompatibility. Very important is sepsis screen, and if required, you can do the liver function test or thyroid test or torch assay. Now complications. Very important complication of the neonatal jaundice, and that too is the pathological jaundice, is the kernicterus, which occurs if the acute bilirubin encephalopathy causes permanent damage to the brain. There may be attenuated cerebral palsy, permanent upward gaze, hearing loss, improper development of the tooth enamel. This kernicterus is subdivided into three groups. That is a classical kernicterus, where there is a tetrad of auditory neuropathy, neuromotor symptoms like dystonia, hypertonia, acidosis, oculomotor paresis, and enamel dysplasia of the deciduous teeth. Or it may be auditory kernicterus, where there is a predominant auditory symptoms are there, or motor kernicterus, where there is motor symptoms are more. Then second complication is acute bilirubin encephalopathy, divided into three phases. In first phase, there is a hypotonia, poor sucking in first few days of life. In second phase, there is a hypertonia, retropolis or apostrophe posture, and fever is there. Third phase, gradual disappearance of hypertonia and up to years after first week. Third is the chronic encephalopathy. There is a Feinstein tetrad is there, which includes extrapyramidal abnormalities, hearing loss, gaze abnormalities, and dental dysplasia. Also, there is a cerebral politics is relatively spared, so intelligence may be normal. No treatment. Just we have seen physiological jaundice is transient and mild. It does not require any treatment. Only thing you have to exclusively and frequently breastfeed the baby. Mother should be admitted if required, and she should do the breastfeeding. Now, there is a role in the exaggerated jaundice or pathological jaundice. First one is the Bailey blanket. This is a portable phototherapy unit only, and where the baby tie the Bailey blanket on the chest and abdomen, and main mechanism is of the phototherapy. Phototherapy is exposure of the baby to certain rays of light, and it is ancient practice where sunlight is used to reduce the neonatal jaundice. These are the old pictures where the sunlight is used as a treatment part of the neonatal jaundice. Also, invention of the phototherapy was in 1950. It was done accidentally at Rosford Hospital at Essex in England, where a nurse, Sister Jean Ward, who noticed that babies who are exposed to sunlight has reduced incidence of neonatal jaundice. Especially, she noticed that those babies who are on the side of the ward where the sun exposure is more, where the neonatal jaundice percentage is less. Also, pathologist Dr. Perryman, who has noticed the vials of the blood left in the sun had turned green and the bilirubin level was less when he was doing the serum bilirubin assessment. Then Dr. Kramer, Richard, and Dobbs, who put these two observations together and leading to landmark randomized clinical trial, which was published in Pediatrics in 1968, and took another 10 years for practice to become established. Niels Reber Finsen is a Danish physician who is known as modern founder of the phototherapy. Basic mechanism in phototherapy is bilirubin absorbs light optimally in the blue-green range of the 460 to 490 nanometers, where bilirubin is photoisomerized and excreted in the bile, which is converted into lumibilirubin, which is excreted into urine. In phototherapy, eyes and genital eyes in the boys should be covered in order to avoid the direct exposure and trauma to genitals. It is important to maintain the hydration and urine output when you keep the baby under the phototherapy. Use of phototherapy is not advocated in the conjugated type of neonatal jaundice. It may lead to the bronze baby syndrome, which is related to the grayish brown discoloration of the skin, serum, and urine. Now, very important, after phototherapy is discontinued, there is increase in the total bilirubin level is known as rebound bilirubin. And phototherapy does not involve ultraviolet light therapy. The distance between baby and tube light should be 45 centimeters. The penetration power of the phototherapy is 2 millimeters. This is the basic thing. Preferable to use the either daylight, which provides enhanced clinical observation and adequate efficacy, or blue-green light. The PP is done every 2 hours or after each feed. Temperature is monitored 2 to 4 hourly. Weight is taken daily. More frequent breastfeeding is advocated, or more 10 to 20% of the extra IV fluid is given because of warm environment. Serum bilirubin is monitored 12 hourly, and phototherapy is discontinued if 2 recordings of the serum bilirubin is less than 10 milligrams per deciliter. There are few side effects. There is the increase in sensible water loss, loose green stools, hypothermia or hypothermia, rash, oxidative injury, bronze baby syndrome, or ultraviolet light irradiation. Next modality of treatment is exchange transfusion. But nowadays, because of all the most of delivery occurring in the institute and good neonatal practice, incidence of exchange transfusion is less, but still it is advocated if the serum bilirubin is more than 25 milligram per deciliter, and where there is a risk of neurological dysfunction, or where we can't advocate phototherapy. In this process, you remove the bilirubin from the circulation, and in isoimmune hemolysis, which removes the circulating antibodies, which sensitizes the RBC as well. Double exchange transfusion and single exchange transfusion is performed depending on the underlying condition. Complications also occur like electrolyte imbalance, hypocalcemia or hyperkalemia, cardiac arrhythmia, thrombocytopenia, blood-borne infection, etc. The conditions which we prefer the exchange transfusion is the RH isoimmunization, where the RH negative or blood group O blood is used, ABO blood incompatibility, G6PD deficiency, which can use. Now, this is a Mazel chart which can determine what treatment to be given according to birth weight and the duration of the neonatal jaundice, and depending on the serum total bilirubin level, whether to do the phototherapy or exchange transfusion, or phototherapy and exchange transfusion. Commonly in between 5 to 9 milligram per deciliter of the serum bilirubin. Within 24 hours, phototherapy is indicated. If it is more than 20, exchange transfusion is exclusively indicated. If the serum bilirubin is 15 to 19, you can give exchange transfusion and consider phototherapy. This is a total lay diagram of the exchange transfusion. After phototherapy and exchange transfusion, some of the cases we have to deal with a pharmacological treatment. Commonly used drug is the phenobarbital in the dose of 5 milligram per kg body weight, and it can be given prophylactically or as a treatment part, because phenobarbital increases hepatic uptake and conjugation as well as excretion of the bilirubin. Next drug is intravenous immunoglobulin in high dose 0.5 to 1 gram per kg has shown some positive results and need the decreased exchange transfusion and phototherapy in RH incompatible babies. Also, you can give the metalloporphyrins. Also, you can give the agar, which helps to decrease the enterohepatic recirculation of the conjugated bilirubin. Also, you can give the glycerin suppositories in order to facilitate the stool to be passed and evacuated early to prevent the hyperbilirubinemia. Also, you can use the enteral prebiotics, which helps in enterohepatic recirculation and which prevent the neonatal jaundice. Also, L-aspartic acid, which is also helpful in the neonatal jaundice. Now, follow-up. Babies having roughly 20 milligram per deciliter serum bilirubin and that requiring exchange transfusion should be kept under follow-up in the high-risk clinic for neurodevelopmental outcome. Hearing assessment, that is BERA, brainstem evoked response audiometry, should be done 3 months of the corrected age, especially those babies who receive the exchange transfusion. Prevention, especially in the physiological jaundice, is by early and frequent feeding, adequate hydration. RH incompatibility, you can give the anti-D immunoglobulin. Prognosis with treatment is very excellent, and those who have delayed treatment, brain damage is a major complication which occurs especially in the pathological jaundice. Now, in short, we have seen this neonatal jaundice, which is broadly divided into two groups. It may be conjugated or unconjugated. Conjugated may be hepatic or post-hepatic. Unconjugated may be physiological or pathological. Pathological may be due to the hemolytic, non-hemolytic sources. And neonatal jaundice is totally different from the adult jaundice. Here in neonatal jaundice, you can think of the involvement of the nerve if the treatment is delayed. Neurological damage is very, very common if its treatment is not given at the proper time. This is in short about the neonatal jaundice. Thank you.